We'll start, ma'am.
Yeah, we just check with Asha ma'am and then you can
Yes,
start.
yeah, sure.
So, good evening to one and all. It gives us great pleasure to welcome you all back to our Advances in ART Masterclass series. So, as you all know, we have two masterclasses on second Thursday and fourth Thursday, one embryology and one advanced ART. And it is truly an honor to have a pioneer like Asha ma'am to join us this evening. And it really shows the passion that she has for academics and for teaching. Despite her busy schedule, she has accepted. Before Dr. Vasundara introduces Asha ma'am, I just make a few announcements. So our upcoming master classes are the first week of July. On 9th July, we have the Heart of the Lab Mastering IVF Incubators by Dr. Chakra Joshi, who is the past chairman of embryology of Indian Society of Assisted Reproduction. And on the 23rd of July, we have Female Fertility Preservation by Dr. Shobhana Patel ma'am. And so these are the master classes for the month of July. And as next slide, as you're all aware, the immune code, which is Vasundara ma'am, would you like to say about?
So it is a unique reproductive immunology conference in collaboration with Scale and Gunashila, which is going to happen on 25th and 26th of July 2026. So those who are interested in this upcoming complex field, please join us for this conference. It is very unique because we are going to have hands-on workshop on LIT. You can learn the methodology totally. Second is interpretation of these immunological reports, real case reports, how to interpret them. And we have international faculty who are authority in reproductive immunology also teaching us in this 2 days conference. So do join us at Bangalore. So without much ado, today it is indeed a great privilege and an honor for all of us who have joined us today, because we are having a pioneer in the field of reproductive medicine. Especially so, Madam has done so much work in endometriosis and adenomyosis. We are indeed greatly honored to have you here, ma'am. And Madam is the director of Rao Hospital and Care, Coimbatore. Madam is the Director for Postdoctoral Fellowship Programs in Reproductive Medicine and Endogynecology and is affiliated to Dr. MGR Medical University, Tamil Nadu. And indeed, she is a gold medalist, exemplary clinical and academic leadership. She's honored by the President of India and a true pioneer in the field of reproductive medicine, having delivered the first ICSI baby and first vitrification baby of Coimbatore. Madam has served as a chairperson of Endometriosis Committee, FOXY, is an ICOG Governing Council member, past president of Coimbatore Obs-Gynae Society, and currently is the VP-elect FOXY South Zone 2028, a testament to the immense respect that she commands from our fraternity. She has edited the FOXY Focus on Endometriosis and co-authored the landmark book on endometriosis clinical management, and has trained generations of specialists through her postdoctoral fellowship program in reproductive medicine. Tonight, Madam is going to bring her unparalleled expertise to one of the most challenging intersections in the field of reproductive medicine, adenomyosis in ART, which is definitely perplexing for both the clinicians and the patients. So without much ado, the virtual platform is all yours, Madam. We are all waiting to learn from you.
Thank you so much, Vasundara, for those kind words. And I've heard so much about the good work being done by your team, the Chakra, yourself and Dr. Sindhuja. And I've always enjoyed watching your growth. And I wish you the very best in your future. And now to start, today's topic is very close to my heart. Adenomyosis, I think. Let me just start. Can you see it? Can you see the slides?
We can't see. No,
not yet.
Not yet. We can't see, ma'am.
Now?
It's loading, ma'am. I think it will come in a minute.
Okay, fine. Because there's a bit of a lag, I think. Can you see now?
Yes, ma'am.
Okay. this topic on adenomyosis and ART, a practical guide from diagnosis to live birth. Quite a lovely heading. And I think I have been we have grown studying adenomyosis for almost 30 years, I would say. My first experience perhaps would be in 1992 when a girl who was 90 kilos, quite an obese girl with the infertility of 18 years, and yet she was only 34 years. No, she had married very young. And she came with severe dysmenorrhea and infertility. And when we did a laparoscopy, she showed a globular enlarged uterus with bilateral cornal block. This was 1992. And those days we did try tubal cannulation because we were already doing hysteroscopy, but there was no spill. And we put her on danazol for about 4 to 5 months. And we stopped it. She promptly conceived. And the child born in 1993, you can imagine, she's about 33 years now, a busy executive. And since then, I think we have been making a lot of study on adenomyosis and the disease which is known for severe menorrhagia, dysmenorrhea, pelvic pain, and infertility really brings down the quality of women's life. And though it is said to be associated more often with Paris women above 40 and said to be diagnosed historically by histopathology and hysterectomy, today it is seen more and more in younger women and women who are infertile. So there is so much of change in the scenario. And by definition, it is benign invasion of endometrium into myometrium, producing
I'm sorry to
uterine
disturb
enlargement.
you. The slide
And
is
it
not
also shows
moving, ma'am.
endometrial. What's the slide now?
The topic slide, ma'am.
Because here everything is moving.
Sindhuja, can you
Now the
confirm
slide is
that?
adenomyosis.
No, ma'am, I cannot.
The slide is in the topic slide, correct? Yeah, now it's moving.
Now
Yes.
it's moving.
Now it's in the adenomyosis, abnormal uterine bleeding, pelvic pain, and infertility slide, ma'am.
Yeah, every time it's one slide behind, Now it is here benign invasion of endometrium into myometrium.
No, ma'am. It's in the...
Producing diffuse enlargement of the uterus. That's a slide.
No, ma'am. It's in the adenomyosis, abnormal uterine bleeding, and infertility slide.
Ma'am, is it in presenter mode, ma'am?
Oh, I'll just call my person who is outside.
Or if there is a internet issue also, it can happen. So sometimes if you switch off your video and...
Switch off the video, okay.
But you know,
Screen sharing has stopped as the shared window is screen sharing has stopped. It says screen sharing has stopped as the shared window is closed. Slides move ஆகுறது இல்லைன்னு சொல்றாங்க. நமக்கு என்ன ஸ்லோவா இருக்காங்க என்ன சொல்றாங்க? என்ன மூவ் இருக்குன்னு கேட்டாங்க. Can you see it now?
Not yet, ma'am. It is just loading, I think.
What do you see? It's a...
Yes, now we can see.
Can you see the adenomyosis, abnormal uterine bleeding, pelvic pain?
Yes, ma'am. But it is not
Now,
in full screen mode yet.
Pardon me?
You have to make it full screen, ma'am. We are able to see that slide, but you have to make it full screen.
Yeah, it is full screen now. Harish,
No,
only
ma'am, we
three.
can see the slides and the, it's not that full screen mode yet, ma'am.
It is full screen here.
Yeah, now it's fine.
Yes, ma'am.
Now it's fine.
It is, I think there is a lag between you and us. Now?
Maybe with, yes, ma'am, it's fine. Maybe with your video off, you just try moving, ma'am. If there's an
Yeah, now
internet
the video is
slowing.
off.
Yeah, now it's moving, ma'am. Perfect.
Okay, let us try. Okay.
Yes,
I hope it is fine. Okay, adenomyosis, as all of us know, is defined as benign invasion of endometrium into myometrium, producing diffuse enlargement of the uterus. And microscopically, there are endometrial glands and stroma surrounded by hypertrophic, hyperplastic myometrium. And every month when the woman bleeds, there is also a miniature hemorrhage into the uterus, and this cannot escape out. So causes severe menstrual pain, cramps, and also produces abnormal uterine bleeding, chronic pelvic pain, and infertility. Is it moving? Okay. Yeah. And
Yes.
adenomyosis is also one of the members of the Palm-Cohen group of disorders causing AUB. In Palm-Cohen, the A stands for adenomyosis. So whenever there is resistant adenomyosis, especially with pain, you should definitely look for adenomyosis. Okay, it's fine? Yeah.
Yes, ma'am.
Okay, fine. Thank you. Yeah. And the true incidence is difficult to find out because you cannot do really a histopathology. But 30% of women can be asymptomatic, and 21% of women with endometriosis concomitantly had adenomyosis. 28% of subfertile population has adenomyosis alone, and 50% of young women with infertility and dysmenorrhea and or menorrhagia could be having adenomyosis. And as I said, the changing trend is alarming. Instead of women who are 40 and fertile, we are seeing it in younger women, almost in 30% of infertile women, and also seen in 22% of infertile women less than 40 years undergoing ART. And this is a lovely paper by Togas Tulandi et al. In Fertility Sterility, where they concluded that there is a decreased rate of successful implantation and increased pregnancy loss, thus overall leading to reduction in live birth rate. So reduce implantation with ART and increase pregnancy loss. And decreased pregnancy rate, 23% in adenomyotic women compared to 44% in non-adenomyotic women was also seen in the study by Talluri and Tremelin. And gravid women with adenomyosis were also having more often a preterm delivery and PPROM. So adenomyosis causes altered contractility of myometrium, impaired gamete transport, infertility, poor implantation, poor placentation, miscarriage, preterm labor, and IUGR. So from a disease which was associated with fertile women, now we have moved on to infertile women and also women with reproductive dysfunction. So whenever there is recurrent miscarriage or recurrent implantation failure, one has to halt and look for adenomyosis. So how do you diagnose this? It's a disease of the junctional zone. You can see here the beautiful endometrium, myometrium, and this thin space in between a halo is the junctional zone, which is barely 3 to 4 millimeters in normal women. But with adenomyosis, there is a thickening of the junctional zone, and whenever this is more than 12 millimeter by MRI, you can say it is adenomyosis. And there could also be diffuse or local thickening of the myometrium, myometrial mass with indistinct margins, small hypointense myometrial spots, and uterine enlargement. This is how the adenomyosis was studied by MRI. And according to MRI, it has been classified into simple junctional zone hyperplasia. That is junctional zone between 8 to 12 millimeter. And when the thickness is more than 12 millimeter, it is called as partial or diffuse adenomyosis, which can involve perhaps the inner third or 2/3 or more than 2/3 of the myometrium. And adenomyoma is a myometrial mass with indistinct margins with low intensity in the myometrium. It's like a cystic mass in the myometrium, and that's called as adenomyoma. And today we have ultrasound, which is the extension of the examining finger, which is available in almost all clinics. So it's just that apart from the machine, the man behind the machine or the woman behind the machine also is very important. And all of you know about this signs like globular asymmetric uterus, cystic spaces, myometrial linear striations. So if there are more than 2 signs, you can diagnose adenomyosis. And the accuracy is almost 80% even with 2D ultrasound. And today we have the morphological uterus sonographic assessment group, the MUSA criteria. Again, what are these? Echogenic lines and buds, echogenic islands, irregular endomyometrial junction, myometrial cyst, parallel shadowing, asymmetric thickening, and translational vascularity. So the myometrial cyst, hyperechoic islands, and echogenic subendometrial lines, and these are all the direct features. And the asymmetric thickening, the fan-shaped shadowing, globular enlargement of uterus, irregular junctional zone. These are all the indirect features of adenomyosis according to MUSA. So more often, with 2D, you may diagnose like this, a globular big enlarged uterus. But my friends, you have to diagnose adenomyosis like this with the 3D ultrasound. Here you can see the endometrium, the myometrium, the dark space, the junctional zone, and this is the focal infiltration by adenomyosis, the tiny spot. And this is the focal adenomyosis, and this also is a focal adenomyosis. And this is the stage that you have to diagnose adenomyosis. So when you see this in young women, early stage, you can halt the disease, nip it in the bud and help them medically rather than landing up with the surgical management. So kindly use 3D more often, and you can also do a mapping of adenomyosis like this: focal or multifocal, superficial, deep, diffuse, submucous, subserous. All this can be studied beautifully with the help of ultrasound. Today we are also adding color Doppler. Once again, color Doppler helps you to clinch the diagnosis, especially differentiate between myoma and adenomyoma. And this is an adenomyoma. Many people call it as chocolate cyst in the myometrium. It is not. It's an adenomyoma, which is a soft swelling, which can be a cystic lesion and very much amenable to surgical management. There's no point in wasting, multiple doses of GnRH on these women. So this adenomyoma, which is a cystic lesion in the myometrium, responds beautifully to surgery. So it's very important to differentiate this from myoma or other adenomyosis. And how does this happen? Pathogenesis, all of you know that the most common theory is downward invagination of the endometrial basalis layer into the myometrium. And Leyendecker et al. Showed that uterine autotraumatization and initiation of the mechanism of tissue injury and repair, it's called TIAR. This could be the primary cause of adenomyosis. There is a local hyperestrogenism in these women, which causes increased peristalsis, tissue injury, and repair. So there's a diffuse uterine enlargement, there is myometrial hyperplasia, and there are also so many changes in the endometrium. And in the endometrium, you can see the factors that are adverse to implantation, like beta-catenin, CD68, macrophages, and natural killer cells. These are all increased. And the factors that are favorable to implantation, like HOX01A, HOXA10 mRNA, integrin, interleukin, selecting ligand. So these factors which are favorable to implantation are decreased. So thus leading to infertility. And at the endometrial level, there can be gene dysregulation of endometrial proteins, altered endometrial function and receptivity at molecular level, impaired implantation, altered decidualization, there is overexpression of P450 aromatase, and increased local estradiol production in the endometrium. And the most important is altered uterine peristaltic activity due to the destruction of the junctional zone. Normally during ovulation, you see you can see the myometrial contractions by ultrasound, and these are from cervix to fundus and fimbria to fundus, favoring ovum transport and also sperm transport, favoring fertilization. And after ovulation, these contractions quieten down, favoring implantation. But here there is hyperperistalsis and altered peristaltic activity because of destruction of junctional zone. And this could be one of the very important factors that reduces the implantation and also can cause early miscarriage. Once again, Pierce et al. Observed that.
Ma'am, sorry to disturb you, ma'am. Again,
Yeah.
the slides are lagging. It is in the mechanisms through which, yeah.
My God.
Yeah. Now we are in the junctional zone thickness and implantation failure slide, ma'am.
Okay. So maybe there is a slight lag.
Okay, ma'am.
So Pierce et al. Observed that whenever the junctional zone is less than 10 millimeters, the pregnancy rates were 45% per transfer. When the junctional zone thickness went up more than 10 to 12 millimeters, the implantation rates dropped down to 16% and even 5%. So MRI evaluation of junctional zone thickness is the best negative predictor for implantation. Can you see the next slide now?
Not yet, ma'am. Yeah, now it's visible. Yeah.
Okay. So the muscular changes and morphology in adenomyosis vary greatly from slight localized expansion of the junctional zone to massive myometrial hyperplasia and fibrosis, which could be expected to change the plasticity and tonus of the uterus, as well as the contour of the endometrial cavity. So the myometrial hyperplasia can cause a lot of havoc. It can lead to severe abdominal pain during menstruation, and it can also cause menorrhagia and even miscarriage because of the myohyperplasia. And there are multiple studies, 7 studies which reported increase in the number of miscarriage or fetal loss in IVF ICSI studies, which was 32% in women with adenomyosis and 14% in women without adenomyosis. Am I on the right slide?
Yes, ma'am.
This is again a study by Hashimoto et al., where they concluded that the chronic inflammation by adenomyosis has multiple effects like impaired placental perfusion, reduced implantation, reduced placentation, and preterm delivery, second trimester miscarriage, placental malposition, preeclampsia, SGA infant. You can have higher number of small-footed babies, higher NICU admissions, higher chance of PPH, even hysterectomy. You have to explain to the patient these various obstetric complications whenever you take up these patients for delivery. So because today is a day of informed consents, so it's very important to discuss the reproductive problems also with the patient when they get pregnant. And these are all the various studies from 2006 to now. Zhuang et al., Machimoro, Hashimoto, Shin et al., and all of them talk about the increased chances of preterm delivery, SGA infants, preeclampsia, second trimester miscarriage, cervical incompetence. All this can be a problem of adenomyosis. So the treatment depends on the age, desire for fertility, diffuse or focal, and associated other factors. You can have sometimes many times you have associated endometriosis, myomas, hydrosalpinx. So you have to discuss each and every detail that they have. And you should tell them that it's a lifelong management. It does not stop with pregnancy or childbirth. You have to continue to treat these women. And how do you manage? It can be medical management, it can be conservative surgery and ART, or in combination. But there are no proper guidelines and there are very limited data available regarding which modality to use and when to use and how long to use. So I think it is up to our generation to bring in the guidelines. So when we manage ART, manage adenomyosis and help them to get pregnant, the most important is the challenge of volume reduction. It's very important to have early diagnosis, volume reduction, and what has worked today very well is segmentation of IVF and embryo transfer. Earlier, we did a lot of fresh transfers, but today, collection of embryos, vitrification, and then reduce the size of the adenomyosis instead of giving loads and loads of GnRH before egg collection, which reduced, which suppressed the ovary. Today, we do the egg collection, and then we give suppressants like either GnRH analog or antagonist to reduce the uterine volume. And then we do the embryo transfer. So the frozen thawed embryo transfer has really worked wonders for these women with adenomyosis. So what are the methods of management? Surgical management started almost in 1952. Very many methods of surgery have come out. But over the last, I would say, for last 15 to 20 years, we have been leaning more and more towards medical management. Because this is a disease of recurrence, so you cannot go on doing repeated surgeries. So medical management is working pretty well now. NSAID OCP only for people who are not wanting pregnancy. You can give as a mild management. Danazol was wonderful but lost its popularity because of androgenic side effects. What works today is GnRH analogs, Dynogest, aromatase inhibitors, intrauterine system with progestogens, ART, and non-surgical interventions like uterine artery embolization, HIFU. So this is what today's doctors are interested in more than surgery. But surgery also has its own role. So pre-IVF GnRH for 3 to 6 cycles optimizes ART outcomes. And it reduces the expression of aromatase cytochrome P450 in the ectopic endometrium of women with adenomyosis and endometriosis. And these GnRH analogs cause profound hypoestrogenism. So progesterone add-back therapy is very important to reduce the bone loss. Sometimes if you have severe problems of estrogen deficiency, you can give a small dose of estrogens also. But more often I have given progesterone add-back therapy. And I think we started using GnRH analogs as early as 2006. So I would say almost for 20 years, this remained our friend until I would say 2025 when we started getting the antagonists in India. Until then, GnRH analogs were our trusted friends because when you use GnRH suppression for 2 to 6 months, the mean uterine volume significantly reduced from 180 ml to 86 ml in the papers by Zhu et al. And also Niu et al. Studied and concluded that pre-embryo transfer GnRH analogs can definitely increase the pregnancy rate, ongoing pregnancy rate, and implantation rates in patients with adenomyosis. And this is a paper by Holmes et al. From Netherlands, which concluded that there was no difference in any of the IVF ICSI outcome in women with and without adenomyosis when you give long-term GnRH suppression before IVF ICSI. And this is the paper by Niu et al. Where he showed that long-term GnRH treatment before IVF ET might improve the pregnancy outcomes in women with adenomyosis. So the implantation rate went up from 16 to 32%, pregnancy rate from 24 to 51%, and ongoing pregnancy rate jumped up from 21 to 48%, which is really remarkable, though the number of days of stimulation and dose was slightly higher. And how long to use the medical management? Again, there are no guidelines. If you look at the various papers by various authors, Nelson, Silva, Corson, Wong et al., some have used for 5 months, 3 months, 6 months. And Nelson et al. Used for 3 years. So there are no guidelines set. Even at Rao Hospital, we have used more often for 2 to 3 months. And a couple of patients we use for 6 to 7 months. It depends on the size of the adenomyosis. And the rate of euploid miscarriage is generally increased in the setting of adenomyosis. But if you use pre-transfer GnRH suppression, there is a boosting of implantation, and it can also improve the post-implantation pregnancy health. So the number of miscarriages came down when you used pre-embryo transfer GnRH suppression, and the number of premature deliveries, PPROM, all this were reduced when we use pre-embryo transfer GnRH suppression. This is a patient of ours who had recurrent implantation failure elsewhere. When she came to us, we saw this subtle adenomyosis in the posterior wall. It is not very large, but there was increased vascularity. We suppressed her with the GnRH analog. At the end of 12 weeks, You see it was got suppressed very well except for 2 cystic spaces in the myometrium, and the endometrial expansion also was good. And with the embryo transfer at 16 weeks from starting the GnRH analogs, and she conceived twins, and she did very well, resulting in a live birth around, I think, 34 to 35 weeks, which was pretty good. This is another patient with a posterior wall adenomyosis. You can see it is 4.7 centimeter. She has had prior IVF failures elsewhere, and she also had chocolate cystectomy earlier. And you definitely do 3D. Very important. It shows a good delineation of the adenomyosis, which is 4.7 centimeter, almost compressing the endometrial cavity. So very tempting. Whenever I give this in the panel discussion, many people say, let us do adenomyomectomy. Let us do a hysteroscopy and scrape this lesion. But all that we did was we suppressed her for about 16 weeks. But before that, we did the egg collection because the ovaries were rather small. AMH was around 1.4. So we did embryo freezing followed by suppression for 16 weeks. And when we did the embryo transfer, she conceived, and the child is, I think, this was a picture in 2016. So the child is now 10 years. So there was a very happy ending without surgery. And Dynogest is a favorite of many doctors. It's very good for the suppression of chronic pelvic pain, but it's not good for the control of menorrhagia or for reducing the uterine volume. So it reduces the pain, but does not suppress the uterine volume that well as compared to the GnRH analogs. But it maintains a good estradiol level, so does not cause bone loss like the GnRH analog. So this is a paper by Matsushima et al. They made a comparison of GnRH analogs, low-dose estrogen progesterone, and Dynogest for 16-week study. So with GnRH analog, the volume came down from 307 to 177 cc, which is really remarkable. Whereas low-dose estrogen progesterone and Dynogest, you can see there is no change in the volume at all. It is around 220 and 230. So the volume reduction quickly happened with the GnRH analogs and not with OCP or Dynogest. So it is not ideal in women where you want a quick reduction in uterine volume. It's okay when in delivered women where you want a pain control. Aromatase inhibitors are also very good for reducing the uterine volume of adenomyoma. And a combination with GnRH works very well. A combined use of aromatase inhibitors with GnRH can reduce the uterine volume by almost 60% when you use it for about 8 to 12 weeks. Again, give progesterone add back for preventing the bone loss, which is very important. And there have been papers which showed that a combination of aromatase plus GnRH analog versus Dynogest, the pregnancy rates were 48% in a combination of GnRH with aromatase compared to 20% after Dynogest. So in our clinics, whenever there's resistant adenomyosis, we were combining GnRH analogs with aromatase inhibitors and norethistone acetate for volume reduction. Intrauterine device. It took some time for the scientists to accept this in infertile women, but now we have realized that it's pretty good as an additive in volume reduction, and it acts locally and causes destabilization of the endometrium and adenomyotic deposits. It can be combined with the GnRH analogs, and especially in women with thick endometrium, it works very well. You can always give GnRH analog lipo. I give 11.25, and after about 6 to 8 weeks, I introduce the Mirena. So the expulsions are very much less. And this is a study with the LNG-IUS. The implantation rates were 32%, whereas in controls, it was 22%. And the pregnancy rates also were 44% with the LNG-IUS group compared to 33% in controls. So on and off, we are combining GnRH analogs with intrauterine, the LNGS intrauterine device. This is one of our patients in 2020. She came to us in the COVID year, married for 4 years, 31 years with severe dysmenorrhea, infertility, and she had a history of ectopic and Male factor was normal. She was also a mild diabetic. She earlier had a laparotomy elsewhere for a 12 centimeter myoma. And she also had a polypoidal endometrium and a tubal factor. So she had diffuse adenomyosis, posterior wall nodule. Uterus was about 12.7 centimeter. There was 216 cc volume, which is a pretty. Uterine volume normally is around 60 to 50 to 70 cc, but this was 216 and a thick endometrium and a posterior wall adenomyosis. But very good AMH. She had an AMH of 4 or something. So she underwent a laparoscopy because she had a hydrosalpinx, tubal blocking done, followed by ovarian stimulation. And this lady, we had done a long suppression because of her good AMH, embryo freezing done, and FET done. In spite of that, it failed because we realized that though the uterine volume came down, uterine cavity was still 12 centimeter and the endometrium was thick. So then we gave her an intrauterine device. Along with that, JNRS suppression for another 4 months. And when we did a second transfer, the uterine cavity length came down to about 8.6 centimeter, which was quite impressive. And we had transferred 2 embryos, it became triplets. But fortunately, in her 11th week scan, we saw that one set of twins got reduced spontaneously, and she continued a singleton pregnancy and did very well and had a baby at 37 weeks. So this was in the COVID year. She had a suppression for almost 7 to 8 months with the JNRH and later with the intrauterine device. And today we are in the era of JNRH antagonists, very quick suppression. We have elagolix 150 milligram or 200 milligram. You can use 150 milligram OD, 150 milligram BD. But our favorite for adenomyosis more often is 200 milligram twice daily. But we use it for a short period like 8 weeks, 12 weeks, and not for long term really. We have the medication available for us for about since November last year. I would say it's about this November, it will make it 24 months. And we also have relugolix today, 40 milligram. Both these medications cause volume reduction, but it's much more rapid with elagolix. But both of them can cause estrogen deficiency, and they do cause bone loss. So one has to be very careful while using them. Do not use haphazardly. Either always use it with under medical observation. This is one of our patients. She came to us unmarried at 28 years with severe dysmenorrhea, and she gives a history from the age of 10 years. She describes how she had menarche at 10 or 11 years, and then she had menorrhagia, and after few years at the age of 15, 16, she had dysmenorrhea. She was on various types of OCP. And when she came to us at the age of 28 years, she had a uterine volume of 196 cc with focal adenomyosis, and she was a PCO. That's a blessing for her. And small chocolate cysts in the right ovary, 2.8 centimeter. This was the initial picture in 2020. So she already had taken Dinoges before she came to us. So we gave her injection Lupride depot. She was very happy. And you can see here, March 2020, she had Lupride 11.25. And from 196, her uterine volume came down to 87 cc. And the adenomyosis volume also, size also came down. But when we stopped the JNRH depot, again the uterine volume started going up. So next year again it was back to 151 cc. And we cannot go on giving JNRH analogs for more than 6 months. So now we gave her letrozole plus regestrone without JNRH, but there was no action. She was 167 cc. Then she had an intrauterine device. Though she was unmarried, she agreed for the intrauterine device. And but within 3 or 4 months, there was an expulsion of the device because her cervix was really patulous. So then later we gave her even danazole. We gave her initially orally and later we gave her vaginally because there are papers that vaginal danazol works very well. So she had vaginal danazol for about 6 to 8 months. And in Jan 2023, that is 3 years after coming to us, she got married. And now the uterine volume was about 117 cc. And she tried for a natural pregnancy for about 1 year. It was not working. So in 2024, she had a collection, 9 oocytes, 8 M2 oocytes, and I think she had about 6 embryos vitrified. But again, after, they get a bolus of estrogen stimulation with egg collection. Most of my patients we have seen after egg collection in adenomyosis, the uterine volume goes up. So her uterine volume went up to 274 cc within a month after egg collection. And then it wouldn't respond to the GnRH suppression. So we kept trying for about 6 months. And then we had to convince ourselves that this lady deserves. She even had a leupride depot with LNG-IUS, but didn't help her. Uterine volume continued to be around 257 cc. So we did her adenomyomectomy and also the cholecystectomy. And the uterine volume came down to about 148 cc. But we wanted further reduction in uterine volume. So we gave her Egolix, 200 milligram twice daily for 2 months, and again once daily for another 2 months. And now the uterine volume did come down to 73 cc, which was really remarkable. You should learn to measure the uterine volume. So you should have a good sonologist with you, because if you're a busy clinician, you may not have time to do so much. Her first FET was negative. After 2 months, again, with the Progenova that we gave for HRT, the uterine volume had come down to 137 cc. So we suppressed her again with the Egolix for about, I think, 6 to 8 weeks. Second FET is positive. Her uterine volume there was 91 cc. And she has delivered a child last month. She delivered at the stage of 32 weeks. But she has done well. The baby was about 1.3, 1.4 kilos. Baby was in the NICU for about 3 weeks. And both have done very well. No PPH. There were no additions during surgery. This was her uterine volume before surgery, 257 cc. You can see the globular enlargement, asymmetric enlargement. And post-surgery, it was 148 cc. You can see the beautiful triple line evolving here. And before embryo transfer, it had really come down to, I think, once it was 70 and next time it came down to 90 cc at the second transfer. And yeah, these are all her scan pictures. She has done very well. So I would like to say that Egolix works very well for uterine volume reduction. We have a study, ongoing study. We have seen almost 40 to 50% uterine volume reduction in 3 to 4 months in most of our patients. So I think for a quick reduction, Egolix works very well. Use it carefully. So with all this medication available, who will benefit from uterine sparing surgery? So my son Damodar always says, you are suppressing everybody with medication. So when do I get a chance to do the adenomyomectomy? So if there is abnormal uterine bleeding or severe dysmenorrhea not responding to medication, or recurrent implantation failure. So I showed you the patient just now who had severe dysmenorrhea and uterine volume was not responding to medication. For that girl, we did a surgery. So recurrent implantation failure, recurrent abortion, or symptoms not responding to medication is the only indication for surgery. Otherwise, you have wonderful medication which will work very well. Because with surgery, there is a good pregnancy rate, but one can have almost a 6 to 8% chances of uterine rupture in spite of best hands. Japan has the highest number of cases with adenomyosis, and they have done a very good study in almost 2,000 patients. And they quoted a rupture uterus rate of 6 to 8%, which is very high. After cesarean, you hardly have, I think, 0.1% uterine rupture, and post-myomectomy, you have 1% chance of uterine rupture. But with adenomyomectomy, they have quoted 6 to 8% chances, because many times the doctors are still young and learning. And the wedge resection of olden days and single layer closure, single flap, I think the ruptures were high. So today we are in the days of triple flap, quadruple flap, etc. So with good suturing, the number of rupture uterus have come down. but still you have a very high chance of recurrence, which is very, very devastating. So one has to be very careful before you offer surgery to them. Try as much as possible medically, because always remember the chance of rupture is there and the chance of recurrence is very high. So always, this is the, various methods have come. This is by Sun et al. And this is by Osada et al. Osada, I would say, is the master of the surgery. And according to him, he has done it more often by open method, the triple flap technique. You can see he finally opens it nicely and opens endometrial cavity, also removes all the adenomyosis from both the leaves of the uterus, and then he does a good closure with the triple flap method. And in his method, the chances of rupture are 0 and the pregnancy rates were around 56%. So this is a report of rupture uterus in Japan. It was a case of twin pregnancy, 33 weeks pregnancy, and they thought it was preterm contraction, and she was getting a retardant drip. In spite of that, they noticed the beginning of a rupture. She was shifted to the OT as emergency, and the baby was saved, though they had to do a hysterectomy. So kindly be good to these patients. Whenever you do a surgery, give full details to the patient. So the obstetrician who treats her next should have all the details of what kind of surgery you have done and how much myometrium you have left behind, and try and ask them to be around the hospital after 28 weeks. So even if there is a small problem, you are able to detect and treat them and manage them well and avoid chance of rupture uterus. So according to Osada, if it's a large adenomyosis, diffuse, you do open surgery, and if it is focal adenomyosis, laparoscopic surgery is very good. Can you see the slides?
Now, no, ma'am.
Can you see the current slide?
Yes, case number 3. Yeah.
Yeah. So this is a lady who was married to her own uncle. She came to us at the age of 41 years, I think, married for almost 18 years. She, gravida 6, para 2, but they died neonatally, 3 abortions, and she came to us requesting egg donation because she had married the uncle. She did not want any change in the sperm, but she did not mind egg donation. But she had a uterine enlargement. You can see it was almost 6 centimeters. So we did initially embryo transfer 3 times, but she did not conceive twice. Third time she failed. And then we suggested to her adenomyomectomy, and she was promptly lost for checkup. After 1 year, she again came back severely anemic and now willing for adenomyomectomy. So blood transfusion, adenomyomectomy. And after 5 to 6 months, we did her embryo transfer, and now she conceived twins actually. And she did very well. She had a section at 34 weeks, and both the girls born in 2009. So you can see how many years old they are. So it was a happy ending in 2009 with twin daughters. This is another patient with the posterior wall cystic adenomyosis. This lady, we did a laparoscopic drainage, put her on GnRH suppression for 3 months, and she had a spontaneous conception after 6 months. And the child was born in 2009, I think. And this is another lady who has had a adenomyomectomy at a local hospital outside Coimbatore, 39 years with married 15 years. Very poor number of eggs and adenomyosis again of 6 to 7 centimeter. She already had a failed IVF also, failed adenomyomectomy, recurrence, and failed IVF elsewhere. So we did her egg donation, 2 doses of GnRH 11.2. That means suppression for 6 months. And those days we had transferred 2 embryos. It became triplets and 1 vanished. And she ultimately had twins at 36 weeks in 2007. And there are alternatives to surgery like uterine artery embolization, said to be not so good for women with infertility. But again, it is coming back and people are trying, and some successes have been reported. Of course, you should always remember the chances of embolization of the ovarian artery, and maybe the AMH can come down. The MRI assisted, this HIFU is being tried for many years. Now again, there is some story of success, more often from China. But it's not available to many of us. Histoscopic ablation is being tried. If it's a cystic adenomyosis protruding into the uterus, you can try histoscopy and reduce the size of the lesion. So, can I take another five minutes? Vasundara?
Sorry, ma'am. I just muted. Somebody has switched on the mic.
Is
Sorry.
it okay to speak for another 5 minutes?
Absolutely, ma'am. Absolutely. Please. Somebody was just switching on the mic. I just closed it.
Because
Please,
Vasundara specifically asked me, which protocol? What do we use for ovarian stimulation? For a long time, the ultra-long protocol used to be everybody's favorite in endometriosis and adenomyosis. But later we realized that the ovaries really slept off. Ovaries got suppressed. There was a patient where the ovary never got stimulated. In fact, I told the patient, go away for about 2 months and come back. So this lady came back later and she got one follicle, one embryo, but she conceived. So later we have stopped giving ultra-long suppression because increased cost and decreased number of oocytes. So today we are in the days of agonist or antagonist. Both are equally good. You can use a luteal agonist protocol if the AMH is good. But if the AMH is average, I would rather use a GnRH antagonist protocol, which works very well. And we do segmentation of IVF. We freeze the embryos and then we do a frozen thawed embryo transfer. In between, we do a GnR suppression prior to FET to suppress the size of adenomyosis. And it works very well. So if the AMH is good, you can have a good number of oocytes by the luteal protocol, which is also called the long protocol. But many of them are endometriotic and poor AMH. So once again, we use GnRH antagonist protocol, sometimes modified natural protocol, because even getting one embryo from them is worthwhile for them to have their own embryo. And this is a study in 2016 where they have compared fresh FET without GnRH analog suppression. And the second is fresh ET with GnRH analog pre-treatment and FET with GnRH analog pre-treatment. This is what most of us are doing now, the last one. So the fertilization rate was similar in all, around 76%. But if you look at the pregnancy rate, the first two groups, the pregnancy rate was 25 and 30%. Whereas with GnRH analog suppression prior to FET, the success rate was almost 40%, 39.5. So today we prefer FET with GnRH analog suppression prior to embryo transfer. And what should be uterine volume prior to embryo transfer? More often they are quoting volumes like 98 cc to 100 cc, or maybe almost up to 110 cc and not higher. So the volume is higher, the pregnancy rates are less and higher chance of miscarriage. This is the paper by Siako et al. Lower birth rate like 25% versus 43%. If the volume is higher, the pregnancy rate goes up and miscarriage chance is higher, like 51% with a higher uterine volume. And 16% when the uterine volume is less than 98 cc, according to this paper. And what about endometrial receptivity? Endometrial receptivity is altered to quite a bit extent. Especially there is a progesterone, there is inflammation because of the adenomyosis, and there is also progesterone resistance. And there is altered expression of adhesion molecules, hyperinflammatory microenvironment, chronic endometritis associated with adenomyosis more often, hyperproliferation of the endometrial epithelium, impaired decidualization. All this can lead to impaired endometrial receptivity. And there is also a higher local estrogen, which can cause a pro-inflammatory condition in the endometrium. And there is an altered ratio of ASR1 to ASR2 with a decreased progesterone expression. But according to the various studies, doing a ERA test does not really work. There is now, I think this is a paper in 2023, which says that there is now evidence that endometrial receptivity assay test is of no use, no practical use for determining whether embryos will implant or not. chronic endometritis, which has an increased prevalence in endometriosis, does not seem to affect implantation rates. So whatever is true yesterday is not true today. So ERA test we regarded for a long time, but today we say that ERA test is of no use. Of course, if you are so desperate, sometimes even the clinicians need a crutch. You can always do an ERA test. Again, serum progesterone concentration at frozen embryo transfer in women with adenomyosis and endometriosis. This is a study in 2026. This is a study of 1,927 women undergoing first single blastocyst FET with adenomyosis. And they have tried hormone replacement therapy and also modified natural therapy. Serum progesterone was measured on the day of embryo transfer. And according to them, mean serum progesterone levels were similar in women with endometriosis, adenomyosis, and controls. The findings were consistent in both HRT FET cycles and modified natural cycles. Live birth rates were comparable among endometriosis, adenomyosis, and control groups. Neither endometriosis nor adenomyosis independently reduce implantation, clinical pregnancy, or birth rates compared to controls. In HRT FET cycles, women with adenomyosis who achieved a live birth had significantly higher progesterone levels than those who did not conceive. So women with endometriosis or adenomyosis do not have lower serum progesterone levels, do not appear to require universally higher progesterone exposure. The concept of progesterone-resistant endometriosis or adenomyosis does not translate into lower circulating progesterone levels. But a subset of women with adenomyosis undergoing HRT FET may benefit from closer progesterone monitoring, as high progesterone levels were associated with higher live birth rates. So there is a paper which I saw that if it is more than 37 nanograms, the results are better. So routine escalation of progesterone solely because of endometriosis or adenomyosis is not supported. So you can see that the theories are changing every day. So there are other papers which I have seen which said that higher progesterone is useful. But in my own clinic, we give the same amount of progesterone support to all our patients. Endometriosis, adenomyosis, poor ovarian reserve, everybody gets the same amount of progesterone, and we do not give higher amount of progesterone for women with adenomyosis, because most often they are getting injection gestone, and this already gives a higher level of progesterone compared to the vaginal gestone. Very many papers abroad are done with vaginal gestone where the levels are lower. So they say that vaginal gestone, if it gives a level of progesterone less than 37, you should substitute progesterone. But our patients are already on injection gestone, which is giving almost 60 to 70 nanograms of progesterone. So I think we're already giving higher progesterone and there is no need to step it up further. So we have done very many papers at Rao Hospital, 2010 to 2016, 56 patients with 44% pregnancy rates and 68% live birth. I'm just going to, and yeah, we had a miscarriage rate of 32%, but live birth of, I think, 68% was still quite impressive. And recently we also put up a paper in Curious. So to conclude, women with adenomyosis associated infertility, when they come to you, treat them like anybody else. Young women, normal male factor, give them a chance to conceive. If there is pain, give them NSAID or give them a short-term suppression with GnRH, analog, agonist or antagonist. And again, maybe allow them to get pregnant, maybe do IUI. Many of them will conceive. So routine infertility workup along with ovarian function and semen analysis. And if they do not conceive, then perhaps you can try ART for them a couple of times. And if couple of embryo transfers, they are not pregnant, or if they have severe menorrhagia, dysmenorrhea, not responding to medical management, that's the only time that you have to take them up for surgery, not otherwise. So be cautious when you do a surgery. And this is a conclusion by Duhom et al. In 2018. According to them, mild disease, few symptoms, standard ART 2 to 3 cycles, oocyte retrieval cryopreservation 1 to 6 cycles according to them. If necessary, do a hysteroscopy, suppress with GnRH analogs, and then transfer the embryos 1 to 2 cycles. No pregnancy, again suppress with GnRH analog for 2 to 3 months, and again transfer the embryos. So this is what we have done. I showed you the patient where the first transfer failed, but again repeat suppression and transfer, the patient was pregnant. So if it's a moderate or severe disease, oocyte retrieval cryopreservation 1 to 6 cycles, hysteroscopic treatment of cysts, GnRH suppression, transfer the embryos, repeated maybe even 2 to 3 times. And if there is no pregnancy, perhaps you can think of surgery. So more often we recommend medical management rather than surgical management. So do surgery only if needed. Surgery can work well for selected number of patients, but remember the chance of rupture uterus are there and recurrence is very high. So to conclude, adenomyosis is a challenging condition to treat in the scenario of subfertility. It is interesting to note that with ART, there was good pregnancy rate and good reproductive outcome in adenomyosis. So well-designed, adequately powered studies are required to find out the impact of adenomyosis on subfertility. So thank you all for a patient hearing. And yeah, we do have ICOG
Thank you,
training
ma'am.
programs. And also,
can we have your video on?
University
We would like to
recognized
see you,
training
ma'am, now.
programs.
Yes. Ma'am, can we have your video on now, ma'am? Thank you so much, Asha.R ma'am, for this extensive, elaborate masterclass, I would say, taking us through the entire textbook of diagnosis, the investigations, how it translates into IVF outcomes, both in terms of pregnancy and also fertility, how it impacts fertility, when does medical management work, when we should do surgical management, including ART protocols and FET preparations. Such a exhaustive topic, and thanks for covering this whole topic and talking to us for the last 1 hour. It's indeed a great honor that you accepted this and did this masterclass for us. Can we take few questions, ma'am?
Sure. Yeah, most welcome.
Yeah. Ma'am, should MRI be a routine in patients with adenomyosis, whoever is going for IVF and embryo transfer? Does MRI really correlate better than transvaginal scan for predicting IVF outcomes?
In our clinic, we rarely do MRI for adenomyosis because we have a very good sonologist who is with us for 33 years. Now, she has grown up with us. So I think her knowledge of adenomyosis, endometriosis, and diagnosis is very good. And we also have very good ultrasound machines. So a good high resolution machine, if you have, and a good person behind the machine, we rarely do MRI. We do MRI more often for endometriosis prior to surgery, because I think we are still not masters with rectal adhesions. So we are still learning. I think Dr. Padma Shri, who is my son, recently took a course with Mala Sibyl. She had a 12 weeks training program for endometriosis and adenomyosis online. So we are still learning. So the rectal adhesions, I think we are yet to be perfect. So that's where we, before the mother operates, we want to do a MRI for patients to rule out adhesions so that later we are not in the soup. Otherwise, just for fertility aspect, we are not doing MRI for adenomyosis because your mapping is very good with the combination of 2D, 3D and the power Doppler. The color Doppler gives you very good results.
Okay. Ma'am, sometimes we just don't see classical signs of adenomyosis on transvaginal ultrasound. It is just myometrial cysts alone that is present, and the endometrium just fails to pick up. It's just a thin endometrium in that patient. So how do you handle patients with myometrial cysts alone? And if at all we do hysteroscopy, how to do that cyst?
See, myometrial cysts, I showed you right in the beginning that adenomyoma, the posterior wall myometrial cyst, which was almost, I think, 6 into 7 centimeters size. which we just drained by laparoscopy, and we gave her a GnRH suppression. Even if there are a couple of cysts, you can either drain them and give a GnRH, or you can excise them and give a GnRH. But if the cysts are close to the endometrium, then you can go by hysteroscopy.
Okay. Somebody
Now
has asked, can we do
also have
GnRH?
microwave ablation coming in.
Yes,
But
ma'am.
microwave, we have not done much. We just called somebody for trial and did 1 or 2 patients. But hysteroscopy is useful if the cysts are closer to the endometrial cavity. Whereas if they're in, if they're in the myometrium or near the serosa, you do more of laparoscopic drainage and again give a suppression.
Okay, ma'am. So
So
as you
earlier
mentioned
we gave
about...
class traditionally by... Yeah,
Yes,
earlier
ma'am.
we traditionally, for 20 years, we used the GnRH analogs. I always said these are my friends in the fertility clinic for last 2 decades, almost from 2006. But today, I have come to love this Egolix, I would say. No, Elagolix, whichever company it is, doesn't matter. But I like the molecule because there is a very rapid reduction in the uterine volume. But if you stop it, again, it springs back. And after OCR, when there is a lot of estrogen being secreted, 2,000 units, 3,000 units with the stimulation that we give, there is definitely a rapid increase in the uterine volume. So you can suppress it altogether after you freeze the embryos. So sometimes we did suppression of the adenomyosis even for 6 to 7 months. Especially 2 ladies during COVID year. I think we did a suppression from February to October, and both were successful with the pregnancies. I think maybe
current
I
status of...
try
But there are people who are just trained and, they started indicated in which group of patients, which type of adenomyosis, and once that microwave ablation is done, how much is the wait period before we do embryo transfer?
Yeah, everybody is doing gaga over the microwave because, it seems to be easy to do it. But almost up to, say, 300 cc uterine volume worked very well for us with the GnRH suppression. Suppression for almost 6 months. Because even if you do ablation or surgery, you have to wait for 4 to 6 months according to uterine volume reduction. So I feel medication is good enough almost up to 300 cc, which is like 12 to 14 week size of uterus. So if the uterus is beyond that size, perhaps you can go in for either surgery or for microwave, whichever you think is giving best results in your hands. Because microwave is still new to us. So
someone has
I
asked
think I
how
would
much...
really wait before I talk about the results. Whereas surgery is still good because when you do a good surgery, good apposition, wait for 4 to 6 months after surgery and it works well. When you do a microwave ablation, you are again worried about the endometrium.
Especially... Exactly, ma'am. Because the technique needs to be much more evolved and much more done by experts, and we should know where to stop, because there was a recent incident in one of my colleagues' clinic that post microwave ablation, the patient actually landed up in uterine rupture very early in pregnancy. So at least during surgery, you have a control on proper technique, whatever is established.
How much you're excising.
Yeah. So, how much myometrium should be left in adenomyomectomy surgery is one of the questions, ma'am.
Yeah, after adenomyomectomy, leave something like 1.5 centimeter thickness. That's good enough. But today we are doing a triple flap closure.
Yes, ma'am.
That also is very important. That strengthens the muscle wall. Whereas a single layer closure is not good enough.
Ma'am, for patients who are undergoing frozen embryo transfer who has adenomyosis, all your patients undergo suppression and then only do the HRT protocol, ma'am? Or any role for MNC FET cycles? Because, if the follicles are there, if we're able to give letrozole and do a modified natural cycle?
You definitely can try modified natural cycle because not everybody is having big uteri, Sometimes they just have a focal adenomyosis, which you can suppress for about 8 to 10 weeks. And later you can, when the effect of suppression is over, you can go in for the modified natural cycle. Because I'm very fond of the modified natural cycle. Because patients can escape this injection gestone and all the pain of because we are still not so happy with just a vaginal gestone, though, quite a few centers are trying vaginal gestone. So
Okay.
you can try modified natural cycles in some patients. Gives excellent
Yes, ma'am.
results.
Yes, ma'am. And you had just shown us a paper that, progesterone resistance doesn't really matter. The serum progesterone levels are different with injectables. So we don't have to really worry about progesterone resistance in adenomyosis. But do you measure the progesterone, ma'am, always? Because I do measure, and sometimes in patients with adenomyosis, I have to step up the injectable progesterone, sometimes even to 200
We always measure
milligrams.
progesterone levels in all our patients on the day of embryo transfer. But we have not seen any difference between adenomyotic and non-adenomyotic patients. So we have rarely stepped it up because of adenomyosis. We treat them like anybody else.
Okay, ma'am. That's quite reassuring from your side. And what is the size of the uterus where medical management works? I mean, like, should we take it as 12 centimeters? Or should we just try medical management first? Like, you had put a very nice slide on indications for adenomyomectomy based on the failure, pregnancy loss, and all those things. So, should we consider the size of the uterus also, ma'am, to consider
Yes, size of
medical?
the uterus is very important. For us, the maximum uterine size that worked for us about 330 cc. 330 cc is something like a 14-week size uterus.
Okay, ma'am.
Beyond that, I would say perhaps uterine volume can regress very well with the GnRH and aromatase. Now, with the GnRH antagonist, it seems to work rapidly. So beyond this, if there is resistance to suppress, then maybe you should go in for surgery.
Okay, ma'am. So even if we are using letrozole with regesterone combination, usually the suppression is around 8 to 12 weeks recommended, correct, ma'am?
I showed you my slide where I said this girl whom we studied from 2020 and she has delivered this year. 2020 she came to us unmarried girl and 2023 she married. So before her marriage, when we tried just letrozole and regesterone, there was no real suppression in the uterine size for her. Initially with GnRH, she was very happy, but she can't afford it for a long time, and we are also worried about the bone loss. So we put on letrozole and regesterone. I'm not impressed. Letrozole works well with the GnRH. Also ran, both together run very well, but letrozole alone seems to be not very good.
Okay.
In our especially the 2.5 milligram doesn't work at all. You have to give 5 milligram.
Okay.
Letrozole with GnRH works very well. We have also used sometimes GnRH antagonists with letrozole in resistant patients. So letrozole requires somebody to run with it, like GnRH.
Yes, ma'am. So what is the washout period for elagolix, ma'am, when you use it before we do the embryo
Elagolix,
transfer?
now that we have learned or we are learning to do even the FET cycles, you know that there is no need for a wash-off period. If you're given prolonged suppression, I would give a wash-off period of about 1 week. If you have suppressed them for about 12 weeks and all that. But some patients, we have learned to taper the elagolix from
Like how you
twice
had
daily,
shown
we bring
200
it
ml
down to
twice
once daily.
daily, then once daily. Okay.
And patients on elagolix, we have not stopped the elagolix, and very next day we start the Progenova. So there is no need for a wash-off period. It can work very well. Because you have learned to use it in the FET cycles.
Okay. Ma'am, many times, this combination, whenever there is adenomyosis,
There
and
is some problem with the net.
so definitely
put
one
up a
of
video
the
again.
this thing is, was I audible, ma'am?
No, I think I missed some question because the audibility was less in between. Can you repeat the question?
Yeah, so I was saying that many times adenoma left with refractory thin endometrium. So
Yes. If the endometrium is thin, it can be a problem. But we have seen pregnancies even with 5 millimeter, 4.5 millimeter
How do
endometrium.
we handle such patients if they are not really suitable? Yeah.
No, we always try everything. We do a little bit of histoscopy and whatever we call it. You nibble with the scissors and then put a balloon and try to inflate the cavity, then give a progenova. And we try the PRP. We have not tried the stem cells yet. But we have seen pregnancies even with 4 to 5 millimeter endometrium. And we do a good endometrial study. And if the endometrial vascularity is good, we have seen a conception even with endometrial cavity volume of 1 cc. The normal volume should be 3 to 5 cc for the endometrial cavity. But somebody with thin endometrium, where we kept on postponing transfer, we finally had to do a transfer with 5 millimeter endometrium, and the uterine cavity size was 1 ml, and she worked well. She did well.
Okay, ma'am. That is a very important message for us that, in adenomyosis, despite all efforts, if the endometrial vascularity is good and you've done good preparation and there's no other factor that's producing thin endometrium, we can go ahead and transfer it even 6
We have tried doing
millimeters.
PRP and then do transfer after a couple of cycles. That also, whenever you're desperate, you do all these things. But we do not really cancel a cycle if it is 5 millimeters.
Thank you so much, ma'am, for such an elaborate presentation. And also one paper by Nalini Mahajan, madam, I think she had put up in the this thing saying that in adenomyosis patients, there is a 20% shift in the receptivity and their ERA would work. But current latest evidence which you put, ERA is not really going to benefit. So some people used to do,
despite the usage of ERA test is coming down.
Yeah, yes, ma'am, yes.
I think, the Spain clinics, which were controlling Nova, I think they were all very fond of the ERA test. Because I think they were the ones who started. We were also fond of the ERA test because sometimes you're very desperate. You do not know how to explain to the patient. So you cling to, the clinician requires a crutch. That's when you tell the patient ERA test. So instead of ERA test, now we have started saying thymosin, the next crutch. So I tell them ERA test, you have to spend some 40,000 rupees. You have to give to the lab. So maybe that will cover the cost of thymosin in desperate patients. So clinician and the patient both require a crutch. So they shifted from ERA to PRP and thymosin in some patients.
Thank you, ma'am. Thank you.
And now that you are going to teach us a little more immunology, I'm sure we will learn new tricks.
So much, ma'am. It was indeed a great pleasure. A lot of things are coming up with immunology of endometriosis and PCOS, the connect between it. And then now you're talking about even patients who have undergone surgery for endometriosis with immunological interventions. There is a slight possibility of natural conception as well. So a lot of things that is very complex in immunology is coming forward.
For your conference. So I'm sure you'll be bringing new aspects into light. Yeah.
Somebody asked.
Yeah, I think we are really having a problem with the net now.
Ma'am, am I audible?
Yes, you are audible. Yeah.
Yeah, somebody has asked about, you had mentioned about training for ultrasound and endometriosis, so they wanted to know the details.
No, that training was from Mala Sibyl. So they can write to her, Mala Sibyl, in Bangalore. They charged about 18,000 rupees for that module. It was online, So it was worth it. She may still be willing to give it. So they can write to Dr. Mala Sibyl at Bangalore. She's a very good sonologist.
Thank you. And madam was also, conducting fellowship programs. Madam had put up a brochure about Rouse Hospital Fellowship Program. So I think mentored from madam. It's an honor to have you here and mentor us today about adenomyosis. Thank you all the delegates for being a part of this masterclass, and we will soon see you again in the next masterclass. Thank you, ma'am. Thank you all the delegates.
Thank you, Vasundara. enjoyed being with all of you, and wish you all the best in
Thank
your
you.
next conference and your future
Thank you.
endeavors. Yeah, thank you. Thank you. Have a lovely evening. Bye-bye.
Sure. Thank you, ma'am.
Bye.
Thank you.